So today what I'm going to be talking about is a TEAMcare study. I started out as a family doctor, and I'm a psychiatrist. I'm at the University of Washington, associate professor. I work in a diabetes clinic. I have done so for about 13 years. And I have to say, this has been some of the best clinical work I've ever done, and you'll see why in a moment. But it really is a wonderful thing. There's a tremendous amount of demoralization in healthcare amongst providers, and I'll talk a little bit about that in a moment. So what I'm going to talk about today is TEAMcare, a primary care program for patients with complex chronic disease and depression. We didn't want to just stick with complex chronic physical diseases. We want to make it even harder. So we had a depression as well, and it works. And I'm going to show you how. So let's go. And of course, Michael really wanted me to focus on the ingredients as well. So I'm going to get into that, summarize the study, but then get into the ingredients. So really look at it from the outside in, but then from the inside out as well. So basically, the next slide, just disclosure slide. I'm also the founder of SamePage, a company that makes educational tools for improving patient-provider interactions. The problem, let's start with the problem. And I have a question mark there. Now, if this looks busy to you, it is a busy slide, but that sort of exemplifies what might be in a chart. Essentially, this is a very complex patient, a 64-year-old married naval shipyard worker, male, uncontrolled type 2 diabetes. Now, for those of you who don't know, hemoglobin A1C, normal physiologic range is 4 to 6%. 9.6 is very high, and a goal is usually trying to get below 7 or so. And so he has out-of-control blood sugars, he has hypertension, he has hyperlipidemia, both of them are out of control, hyperlipidemia being high cholesterol, obesity, and he has a number of other conditions, hypothyroidism, psoriasis, gout, and diverticulitis, kidney stones, and he's on a number of medications. Actually, I would have thought he would have been on more medications, but that's the number of medications he's on. It gets worse. This gentleman's been coming in with fatigue for a long time. Of course, he has hypothyroidism or low thyroid, so they've been checking his thyroid, and it's always in a normal range. But now they finally screened him for depression because when you've got 6 or 7 chronic physical conditions, you never quite get to actually looking for the depression that might be lurking. And in fact, he has major depression, the most severe form of depression, and he didn't know it. And he's had it for a number of years. So why is that important to know? Well, because diabetes and depression are related in the following way. And you can go to the website at the bottom there, where we've done a number of epidemiological studies at the University of Washington and at Group Health Cooperative. And what people know is that basically depression is associated with obesity, inability to quit smoking, physical inactivity, poor self-care, treatment non-adherence, and medical symptom reporting. In other words, it turns up the symptoms, the pain, the bothersomeness of symptoms, not just psychic symptoms, but physiological symptoms. It disrupts the patient-provider relationship, causes disability, complications, mortality, and costs. But, you know, so I've worked in a diabetes clinic, like I said, for about 13 years, and my understanding is from being on the front lines, when patients come, we have our constructs, depression, diabetes, heart disease, and they're important diagnostic constructs. But when patients come in, this is what they experience. Is a jumble of symptoms. It's not depression or diabetes, and we've called this diapression because the experience of a patient with diabetes who's also depressed, and I got an article in Clinical Diabetes. If you just go on Google, diapression, clinical diabetes, you can read an article where we have a case that goes through about what the difference is between depression in non-diabetic patients and depression in patients with diabetes. And that's another challenge in a busy healthcare setting, is that patients don't always know that they're depressed because it manifests in strange ways. But what is the real problem? I had a question mark at the beginning. Was the problem Mr. T? Or is the real problem this, that we're in the era now of the multi-condition patient? We have a log jam of things, tasks to do, and there are 75 million people in this country with 2 or more chronic conditions. We're entering the era now of the multi-condition patient. We need to adjust and just accept the fact that when we're treating people, we have to be treating a number of conditions at once. This is a great article in JAMA, April 2010, that goes over this and the challenges for the U.S. healthcare system. And so it's a bit of a perfect storm. You've got this challenge. You've got the fact that as a healthcare system, the Picker Institute report, the Institute of Medicine, basically say that our healthcare system is a nightmare to navigate. And then the 800-pound gorilla in the room is the fact that we have a demoralized healthcare provider force. Basically, they did a survey of 11,000 physicians 2 years ago. This is at Physicians Foundation, I believe is the name of the website. 11,000 physicians asked, what was the number one thing that's important to you in medicine? And guess what it was? The doctor-patient relationship. The relationship. But the same cadre of physicians that responded, 49% of them said they either wanted to quit medicine altogether in the next 3 years or significantly reduce the number of patients they see. So it's a real challenge. Let's talk about solutions. So we came up with a solution, something called collaborative care. And basically this comes out of, how many of you have heard of the chronic care model? So the chronic care model was birthed here in Seattle. Ed Wagner, Michael von Korff, and others at Group Health came up with this idea in the mid-90s about this idea that we have to approach chronic diseases in a different way. And collaborative care is one of the essences of that. And basically, instead of just the patient and the PCP up in the top left, there's a team, a nurse case manager that works with the patient, with the primary care provider, and then there's, in the case of our study, supervision or case review by an expert psychiatrist who does supervision. And so how well does this work? Well, we've done 3 trials. I was involved with the IMPACT trial, the Pathways trial, and there was a recent trial by Elle and colleagues with Latino Americans. And all 3 trials, these were done in depressed patients with diabetes, and all of them improved depression and function, but none of them changed hemoglobin A1C or diabetes self-care behaviors. Our belief was, gee, if we can just fix that depression, everything else will fall into place. Does anyone have any ideas why that didn't work? It sort of was referred to in the last talk. I mean, there's patterns. We have patterns in our lives, habits. And even if you get rid of the depression, it's not that hydraulic model. If we just treat the depression, it'll get better. It isn't necessarily true. And that's what we found in 3 clinical trials. So we learned from our mistakes. So it gets better because we were willing to consider what we didn't do right and do it better the next time. So what we developed is TEAMcare, a clinical trial and program of multi-condition collaborative care for the ABCD. We said, it's not enough just to focus on the D, depression. We need to actively focus on A, A1C, the blood sugars, B, blood pressure, C, cholesterol, and D, depression. And that's what we did, is we created a team. So this is our team to develop TEAMcare. And this is at Group Health and University of Washington. Dr. Caton and Dr. Lin and Dr. von Korff are the 3 people that have started this 25 years ago. We've all worked with Ed Wagner and his group at Group Health, and this is just one of the offshoots of the chronic care model. And I also want to acknowledge the research team support, intervention nurses, and funding through the NIMH. So what did we do? We really looked for hardest to treat patients. We looked for people with either diabetes and heart disease that had A1Cs over 8.5%, blood pressures over 140/90, or LDLs over 130, and they had to have major depression. So these are patients who are fairly complex, aren't going to get better very quickly. We recruited 214 patients in 14 primary care clinics. So in other words, half the patients received TEAMcare, and basically I'll describe what the intervention was in a moment, and and half of the patients did not. But here are the results. I want to go right to the results, and then I'm flipping it around. I'm going to show you the results, say it worked, bottom line, and then I want to show you what the ingredients were, because that's what Michael wanted me to focus on. Essentially, what we were able to do with one case manager is affect change in all 4 of these parameters. We were able to decrease A1C by 0.6%. In a meta-analysis of trials, diabetes trials, the best that they did on average was 0.48 or something like that. So we were able to beat that. The systolic blood pressure went down by 5, mean LDL went down by 9, and also the SCL score, which is the depression score, went down. So it works. That's a summary. We were able to affect all 4 of those with one case manager. How did we do it? Oh, and we got this in the New England Journal of Medicine. People noticed. They were actually they were interested in this from a medical journal standpoint. So what is the secret sauce? What is the ingredients? How did we do this? So first of all, we recognized that it wasn't enough just to have a psychiatrist, but we had to have case review once a week, 1 to 2 hours, where we went over 30 to 60 cases with a psychiatrist and a primary care doc, either an internist or a family doctor. So in other words, 2 hours of review of about 30 to 60 cases with three nurses where we just reviewed cases. The psychiatrist and the primary care doc up in the top right never saw the patient once, ever. The patient was seen by the nurse case manager for about 20, 30 minutes at a time. And then the primary care provider still saw the patient as well, and they worked intimately together whenever there was a medication change. But what did the patient and case manager do? And I wanted to talk a little bit about some of the things they did. So they did motivational interviewing and enhancement. How many of you know what motivational interviewing is, and how many of you actually do it in your clinics? Okay. And then problem solving and behavioral activation. And basically, I'm not going to get into a lot of detail about these, but the best way to describe motivational interviewing is in the next slide. So basically, it's all about getting patients to be motivated to change, not having something coming from outside. You want internalized change. And to get there, you have to do things like this. Decisional balance is an example. Let me just show you an example. So let's say I'm working with a patient who I want to quit smoking. And I ask them, if you were to quit smoking, what would be the benefit of that, the pro of that? And they're going to give me things like, well, I'd cough less, my wife would be happy, it'd be socially acceptable, my wounds would heal faster. And if I said, well, what it would be, if you just continue to smoke, what would be a downside of that? And they might say, of course, I'd have a higher risk of cancer, poorer health, and my wounds wouldn't heal. Well, if I went to Wikipedia and looked up the pros and cons of smoking, I bet you I could find the same results, right? And that was probably a waste of time to have that conversation. Probably not. It helped us build our therapeutic alliance. But here's a secret. What you want to do is focus on these two discordant cells. What if I asked, what are the pros of you continuing to smoke? I want to know that. We're not going to make any change if we don't have that discussion. So in other words, a person tells me that it helps them deal with stress. I need to know that. It helps them think clearly at work, bless you, and it keeps the weight off. This guy says he's got a bunch of pants in his closet that he doesn't want to get back into, and there's no way he's going to go back to doing that. He doesn't want to lose the friends that he smokes on the stairwell with at work. Those are the only friends he has at work. It's the only thing that makes his work meaningful. And he's going to gain weight if those are the costs of changing. We need to listen to that, and that makes the difference. And so now we can think, how do we work with this person differently? What about problem solving? This is used throughout chronic care treatment, and in depression, it's been shown that using problem solving is associated with decreases in depression. In fact, it's as efficacious as antidepressants in mild to moderate depression. And we have a training institute at the University of Washington. We do national trainings on problem solving just for depression. And the real secret sauce of problem solving is this right here, between generating solutions and decision making. So what we do, we have a structured way of working with patients and say, now you brainstorm, think of solutions, and then we're going to judge afterwards. We'll go over the pros and cons afterwards. That makes all the difference because usually people, especially depressed people, will rule everything out before they even start to talk about it. And it makes all the difference, and they come up with creative solutions. And even if they don't make the changes, they feel better. Feeling bad leads to doing less and vice versa. This is a truism, and this is really the essence of behavioral activation, another form of treatment of depression. And so we really try to activate patients both physically and socially. What about the whole group of us, the primary care provider, the supervisors, and the nurse case manager? What are we engaging in? In addition to doing what the nurse is doing, it's in the context of treat to target, which I'll describe in a moment, but where we relentlessly and systematically look at all the medications that person's on and make changes over time. There's also a weekly case review, and we have to use a registry. So what's treat to target? It's treatment titration, frequent and consistent, relentless, where we have to increase to the next step and document it. And if we don't, we document that as well. And we work as a team, but that means that we have to have feedback. We have to know what their blood pressures are. So we give people Omron cuffs or make sure they go to the fire station. We need to make sure that they're starting to monitor things. We bring the patient in that next nested example. The patient is part of the team. And so they're simplified and uniform approaches to achieve targets with medications. So here's an example of what happened with Mr. T. He started out 10 is the cut point for major depression. His score was almost double that. We started them on an antidepressant, citalopram, and then we eventually had to augment it. Now, often patients in primary care get put on one dose, and then 9 months later they're on the same dose, just because there's so many other things to take care of. This allowed us to have an ongoing discussion with feedback. Every session, every week, we'd measure depression scores. It only takes a minute, and we were able to then augment this antidepressant with another one, continue to work with problem solving, which is evidence-based for depression, and then we also recognized there was depression in the spouse, so worked with the family system. A1C, or blood sugar levels, also got better by using motivational methods, addressing emotional eating. We were able to finally start insulin on this guy. For 10 years, clinicians wanted to start insulin, and it wasn't possible. But with a team approach, we were able to do that. Nutritional counseling, daily insulin requirements dropped eventually, and his A1C went from about 9.6% to about 6% over this many months here. The red bars are the study, and the blue bars are the usual care. So this is oral hypoglycemics, insulin, antihypertensives, lipid-lowering agents, and antidepressants. And basically, we had significantly more medication adjustments in the group. Again, because there was a team approach, there was treat to target, a review of symptoms and parameters on an ongoing basis, and people didn't fall through the cracks. And we approached people either in person or by phone. The final secret sauce here, and I'm going to finish up, was that we used a registry. Every single patient, every time we met, once a week, every patient would be on this list, just a line. Here's their PHQ score at baseline and now. Blood pressure, hemoglobin A1C, and LDL. And basically, whenever there's an asterisk, it means that that indicator is out of control. So what it allowed us to do is sort patients and make sure we really approach things in a systematic way. We used something like this. When the person that was presenting the case talked, someone else on the team would be writing things down from the team. There was a little checklist of reminders, things we should do. And the team worked together. And then we'd Xerox this, and everybody had this. And then through the week, we'd work on it. But remember, most of the action was in that 2 hours, plus the half-hour visits the nurse had. So, last thing, and I'm wrapping up here. You know, we always, in the literature, you see people talking about challenges with patients, poor collaboration, non-adherence, they miss appointments, they're dissatisfied with care, and so on. I say, let's put a mirror up to ourselves, clinicians. What about us? How often are we not really available to patients? We don't collaborate well. We're not adhering with guideline-level treatment. We miss appointments. We might be there, but we're not really present, okay? Our usual way of doing things in medicine is through a go-it-alone approach. This is an alternative to that so that we can deliver better care to complex patients. Thank you very much. And here's our website right here. Great.